Welcome back to MLT 130. In today's lecture, we're going to be covering the outline for Unit 5. And this is going to be an outline versus the PowerPoints that we're traditionally used to for these courses. And in this outline, we're going to be covering several different topics. The topics include vitamins, irons and other trace elements, porphyrins and hemoglobin, the pancreas, and some concepts dealing with the gastrointestinal system. So the first topic that we're going to look at in this outline packet is vitamins. So what are vitamins? They are organic molecules required by the body in small amounts for normal metabolism. And of course, metabolism is the process by which the body changes food or drink into energy. Most of our vitamins are obtained from the diet. Some are formed endogenous or within the organism. Others are produced in the intestines. Clinical evaluations are usually performed when a patient is suspected to have a vitamin deficiency. Sometimes vitamin levels may be tested if hypervitaminosis is suspected. There are two groups of vitamins. There's fat-soluble and then there's water-soluble. Our fat-soluble include A, D, E, K, and can be toxic. They're absorbed and transported and stored for long periods of time. But water-soluble, some examples are B complex and C, and these are usually not toxic and can be excreted. They are usually retained less and excreted more in urine. They do serve as coenzymes for several important enzymatic reactions in mammals and microorganisms. So what we're going to do now is go through some main vitamins and their characteristics that you need to know about. The first vitamin that we're going to talk about is vitamin A, also referred to as retinol. It's important in vision, cellular differentiation, growth, the immune system, reproduction, and embryonic development. It's usually thought to as being pigmented a orange or yellow. It can be found in fruits and vegetables, green leafy vegetables, and animal products. High doses are found in the liver and fish oils and in organ meat. A lack in vitamin A leads to night blindness, which is also called nyctalopia. And vitamin A toxicity can lead to liver damage. Next is vitamin E, or alpha tocopherol. It is or helps with antioxidants, and antioxidants help prevent or delay cell damage. It protects the red blood cell membrane. It's needed for normal neurologic structure and function. And our sources for vitamin D include vegetable oil, fresh leafy greens, egg yolks, legumes, and peanuts. Next is vitamin D. It's a sterol derivative known as cholecalciferol. A sterol is an organic compound that plays a role in cell structure. It is produced in the skin by the absorption of UV light or obtained in the diet. Vitamin D is essential for bone mineralization and neuromuscular activity. In kids, a lack of vitamin D can lead to a condition called rickets, which is a failure of bones to calcify, so children end up with bowed legs, which then can lead to osteomalacia as adults, which is abnormal bone synthesis. Vitamin D can also be toxic if in excess or too much. Next up is vitamin K, also known as phylloquinone. It's an essential vitamin for the coagulation factor formation. Think back about our coagulation cascade. Think about factors 7 or 2, 7, 9, and 10. It's supplied partially by the diet and partially by the normal intestinal gut flora. It can be found in things like cabbage, cauliflower, spinach, pork, soybeans, and vegetable oils. Antibiotic therapy can cause a deficiency as well as patients on Coumadin. Remember, Coumadin is one of our anticoagulant drugs. And otherwise, a deficiency is usually uncommon in adults for vitamin K. Next up is thiamine or vitamin B1, a condition that is associated with vitamin B1 deficiency is beriberi. This is a disease that causes pain. It's also associated with anorexia and neuropathy. Some food sources for vitamin B1 include yeast, pork, legumes, beef, whole grains, and nuts. A deficiency usually results in poor dietary intake, but in Western countries, a lot of times vitamin B1 deficiency is associated with alcoholism. Next is riboflavin or vitamin B2. The function is metabolism of carbohydrates, fats, and proteins. Food sources include milk, liver, eggs, and leafy vegetables. Deficiency usually related to not getting it in your diet. Symptoms for deficiency of vitamin B2 include lesions of the mouth and skin and anemia. Next is niacin or vitamin B3. Food sources include beans, milk, lean meats, cereals, whole grains, yeast, liver, poultry, and eggs. Deficiency results in a disease called pellagra and usually is found in countries where diet only is based on cornmeal foods. But in North America, alcoholism can be the cause of the deficiency. Next is folate or folic acid. It's synthesized by bacteria. Food sources for folate include liver, spinach, dark leafy vegetables, legumes, orange juice, and some fortified cereals. Megaloblastic anemia is caused by a deficiency in folic acid. There is an increased need during pregnancy for folate and can cause fetal neural tube defects if that folate or folic acid requirement is not met for pregnant women. Vitamin B12 is next, also known as cyanocobalamin. It's needed it needs intrinsic factor to be absorbed. It's found in foods such as meat, eggs, and milk. The deficiency causes pernicious anemia, which is also known as megaloblastic anemia. A vitamin B12 deficiency can be seen in older age people. Also people that are diagnosed with a fish tapeworm or Diphyllobothrium latum, or people that's diagnosed with celiac disease. Celiac disease is a digestive immune disorder that causes damage to the small intestine. It's triggered by gluten. For the B12, the Schilling's test can be ordered. This is an older test that uses radioactive tags to detect vitamin B12 in urine that was not able to be absorbed. For the Schilling's test, you give an oral B12 and an intramuscular B12, and you see what comes out in the urine after 24 to 48 hours. And then finally, we have vitamin C, also referred to as absorbic acid. Vitamin C is a reducing agent in many hydroxylation reactions in the body. Vitamin C helps reduce the risk of common colds and even cancers. A deficiency in vitamin C can cause scurvy, which is a weakness, and can cause anemia, gum disease, and skin hemorrhages. You need more vitamin C in times of stress, inflammation, pregnancy, or when you're on oral contraceptives. Some sources or where vitamin C is found are in things like fruit, veggies, and potatoes. A lot of times people that are malnourished have a deficiency in vitamin C. Some 30 to 50% of hospital patients will have a vitamin C deficiency. This includes our older patients and our patients in nursing homes. And consumption of large doses of vitamin C can also cause serious problems. So basically, you don't have too much of a good thing, because too much vitamin C can also cause major problems for the body. We're now moving on to our next section of the outline. This section is going to cover iron and other trace elements. So let's first discuss iron. Iron in the body is distributed in several different compounds: in hemoglobin, which is in the blood, in myoglobin, which is in the tissue or the muscle, enzymes, and the body sites that are used for transfer and storage. The storage forms are ferritin, which is blood protein, and hemosiderin, which is a brown pigment that is usually derived from the destruction of our red blood cells. Stored as ferritin and hemosiderin in the marrow, spleen, and liver. Of course, women and children usually require more iron from the diet. Absorption in the intestine regulates the amount of iron. Fe3, also called ferric form, is found in food, but to be absorbed, it must be in the Fe2 form, or the ferrous state, and bound to a protein, and it's oxidized by vitamin C. The Fe2 is essential for binding oxygen to hemoglobin and release, maintaining the methemoglobin reductase pathway. Iron deficiency is one of the most prevalent iron disorders and results in anemia. Then there's iron overload, hemosiderosis, which is iron overload without associated tissue injury. And then there's hemochromatosis, which is genetically related primary condition. The body accumulates excessive iron. And its triad of symptoms are bronzing of the skin, diabetes, and cirrhosis. The secondary condition is from patient giving IV iron for anemia. Ferritin is the preferred test when assessing iron status because it is the stored iron. The plasma ferritin concentration declines early in the progression of iron deficiency before any notable changes occurs in the blood, hemoglobin, red blood cell indices, or serum iron. However, plasma ferritin can be increased in some chronic and inflammatory conditions. Transferrin transfers iron from the liver to the bone marrow, and transferrin is a protein that holds iron molecules as it transports iron to the bone marrow. Analytical methods that reflect patients' iron status. Serum iron is performed spectrophotometrically, and it's a measurement based on the release of iron from transferring and subsequent reduction of ferric iron to ferrous iron. Ferritin is the most sensitive indicator of iron deficiency. The total iron binding capacity, or TIBC, is the amount of iron that could be bound by transferring or other iron binding proteins. And the formula for TIBC, or total iron binding capacity, is serum transfer times 1.5. You also have iron saturation, or transferrin saturation, and this is how much iron is bound to transferrin. It's calculated using the formula of serum iron over the TIBC times 100. So that's another formula that you could use. So expected test results for iron disease states. For iron deficiency, you will see a decreased serum iron, a decreased serum ferritin, an increased total iron binding capacity, and decreased iron saturation. Expected results for iron overload. You will see increased serum iron, increased serum ferritin, decreased total iron binding capacity, and an increased iron saturation. For other trace elements we need to discuss, we're going to start off with copper. Sources include shellfish, liver, nuts, legumes, and meats. Intestines absorb dietary copper, and it competes with zinc and iron for absorption. Some copper is bound to albumin. Remember, albumins are protein for transport to the liver for storage, but most is bound to ceruloplasmin. Ceruloplasmin is synthesized in the liver. The function is a component of the enzyme in redox reactions and is capable of converting ferrous iron to ferric iron. A deficiency may be a result of malnutrition and malabsorption. Diseases associated with copper include Menkes disease and Wilson's disease. We've talked about Wilson's disease in the past, so I'm not going to get into that in a lot of detail. But Menkes syndrome is an inborn error of metabolism caused by a defective gene that regulates metabolism of copper in the body. Plasma copper and ceruloplasmin levels are lower than normal. Next, for trace elements, we have zinc. Some sources include meat, fish, and dairy products. It's absorbed in the intestines, and it competes with copper for absorption in the intestines. The next trace element is chromium. The sources include meats and grains. It's important in glucose metabolism, and it activates insulin. Supplementation improves glucose tolerance and decreases total cholesterol in type 2 diabetics. Next is fluorine. Fluorine helps prevent dental cavities, minimizes bone loss, stimulates bone formation, and with vitamin D3 can correct calcium deficiencies and lessen fractures. The last trace element is selenium. It's important for a healthy immune response, has protective effect against cancers, including prostate, colon, and lung cancer. In the outline packet, we're now moving on to the section on porphyrins and hemoglobin. We are first going to talk about porphyrins. Porphyrins are chemical intermediates in the synthesis of hemoglobin, myoglobin, and other respiratory pigments called cryochromes. They are heme precursors, and iron is chelated with porphyrins to form heme. So chelated meaning they're bond. In this case, they're bonded to a metal ion, which is needed to form hemoglobin. Porphyrins are a structure of a ring-containing compound. The rate of porphyrin synthesis is regulated by an amino acid, delta ALA synthetase. There are 3 clinically important porphyrins. The presence of porphyrins in fluid is a sign of abnormal heme synthesis. Protoporphyrins is excreted in feces. Uroporphyrins is excreted in urines. Coproporphyrins can be excreted in both the feces and urines. Porphyria is a disease or condition when a patient cannot convert porphyrins into heme, and it can be acquired or inherited. It's usually due to the lack of an enzyme. The porphyrias can have different classifications. They're either classified as either hepatic or erythropoietic, and this is based on the accumulation if it's either in the liver or if it's developed in the RBCs, or it can be classified as acute or cutaneous based on the clinical manifestations. Porphyrias to know, or that you should know, is PCT or Porphyria cutanea tarda. PCT affects the skin. It usually appears in adulthood, usually following liver disease, or excessive alcohol intake. It is the most common porphyria. Its symptoms include fragile skin, hyperpigmentation, and even blistering. And patients usually have increased uroporphyrins or increased porphyrins in the urine. Next is HCP, or hereditary coproporphyria. These patients are photosensitive. They usually have skin lesions, and they have increased coproporphyrins, meaning they have porphyrins show up in both the urine and the feces. Next is EPP, which is congenital erythropoietic porphyrin. This condition is also known as Gunter's disease. It's an increase in uroporphyrins and coproporphyrins, and it begins in infancy and is associated with hemolytic anemia and cutaneous lesions. It's associated with severe cutaneous photosensitivity. Porphyrin compounds develop in the teeth and bones, and you see red-brown teeth in fluorescence. And lastly, in lead poisoning, you can also see increased coproporphyrins in those patients. So you would see porphyrins in the feces and the urine. For porphyrins, the lab test we can use urinary PBG or porphobilinogen, and the screening tests are the Watson-Schwarz or the Hoesch. These are early reaction tests, and there's a red color change if the samples are positive. And we can test urine, blood, feces, all for porphyrins. Now let's move on to hemoglobin. And the major role is oxygen transport, and it's the major buffering system. It's comprised of 4 hemes, 4 globin chains, and 4 molecules of oxygen. The globin chains, of course, are alpha, beta, delta, and gamma. Hemoglobin A has 2 alpha and 2 beta. Hemoglobin A2 has 2 alpha and 2 delta. And hemoglobin F has 2 alpha and 2 gammas. The known difference between the hemoglobinopathies and thalassemias, the hemoglobinopathies is a defect in the structure of the globin chains, so it's a qualitative defect, and the thalassemias is a defect in the quantity of the globin chain, so it is a quantitative defect. Hemoglobin S is the 6th position on the beta chain, and the valine replaces glutamic acid. So for hemoglobin S, the patient would have the disease if they have SS. If they're just carrying the trait, they would have the trait SA. Some sickle cell patients, if they have the trait, they're given some resistance to parasites such as malaria. Remember, our screening test for sickle cell is the tube solubility test, or the Thyonite tube test. And the confirmation for sickle cell is through electrophoresis. Hemoglobin C, in those patients, lysine replaces glutamic acid on the 6th position of the beta chain. For thalassemia minor, it's a heterozygous, 1 normal gene and 1 defective gene. For alpha thalassemia, if you have the deletion of all 4 patients, it's a condition called hemoglobin Bartz, and cannot make any alpha chains. And hemoglobin Bartz is also known as hydrops fatalis, and death usually occurs shortly after birth. For thalassemia major, this you can have beta thalassemia. Thalassemia major is also known as Cooley's anemia, and you can have microcytic hyperchromic anemia in those patients. Finally, in this section, we need to talk about myoglobin. Myoglobin is a heme protein found in skeletal and cardiac muscle. It's unable to release oxygen except in low oxygen tension. You will see increased levels of myoglobin in muscle damage or seen in elevated early myocardial infarctions. The next topic that we're going to discuss in this Unit 5 outline is the pancreas. The pancreas is both an exocrine and an endocrine gland. Exocrine gland meaning it has ducts to secrete substances into the body. So it's a non-hormone, and it's an endocrine meaning it's ductless. It secretes hormones directly into the blood. So the pancreas, as an exocrine gland, it secretes pancreatic juices containing enzymes into the small intestines to digest food. As an endocrine gland, it secretes hormones into the blood. Pancreas, as the exocrine gland, the cells are acinar cells. The enzymes that are used for digestion include amylase that acts on starches, lipase that acts on lipids, and protease which acts on proteins. The pancreas, as an endocrine gland, the cells are in the islets of Langerhans. The alpha cells secrete glucagon, the beta cells secrete insulin, and the delta cells secrete somatostatin and gastrin. As far as the lab tests, we can check for pancreatic serum enzymes. We can use the amylase to rule out acute pancreatitis, and we can use the lipase also to diagnose pancreatitis. Both serum and plasma amylase and lipase are ordered to check for pancreatitis, but both will be elevated in pancreatitis. But why is lipase often considered the preferred test? Because amylase increases in a few hours and peaks at 24 hours, then returns to normal in 3 to 5 days. However, lipase goes up at the same time but stays up days longer. So that's why it's a preferred test. You can also look at fecal fat for pancreatitis or pancreatic problems. Fecal fat is used to look for steatorrhea, which is excessive fats in the stool, and it can be used to help diagnose malabsorption syndrome. We can do a quantitative fecal fat test, which measures the grams of fecal fats excreted per day. A patient must collect a 3-day stool specimen. We can run a sweat chloride test, and this is usually used to confirm the diagnosis of cystic fibrosis. If we jump down to different pancreatic diseases, of course, we have pancreatitis, which is the inflammation of the pancreas due to autodigestion. Normally, the pancreatic enzymes are in inactive forms called zymogens, then released into the intestines and become activated to digest food. You can have acute or chronic pancreatitis. Then another problem with the pancreas, of course, would be your diabetes mellitus. And you can have either type 1 or type 2. And then there's cystic fibrosis. And cystic fibrosis more often occurs in people of Northern European descent. It's estimated that in the U.S., we have about 30,000 people with the condition, and this usually it's on chromosome 7, and 1 out of 20 people carry the gene. Systems that are involved in cystic fibrosis include the pulmonary, GI, and the reproductive systems. Patients have mucus accumulation, and they usually suffer from recurrent infections and inflammation in the lungs. The median age of survival is now 32, but it used to be a whole lot younger than that. It used to be childhood. The test to diagnose, of course, is the sweat chloride test. And then our pancreatic cancer is another disease, and of course pancreatic cancer has a very poor prognosis. Usually the time people get diagnosed with pancreatic cancer, their prognosis is usually only a few months to live. The last outline that we need to cover in this unit packet is on the gastrointestinal system. The gastrointestinal system includes both the stomach, the small and large intestines, the pancreas, and the gallbladder. The body of the stomach has several types of cells, which include the parietal cells, which secrete hydrochloric acid and intrinsic factor, and chief cells, which secrete pepsinogen. Gastrin then acts on the stomach to cause secretion of gastric acid. There are 3 GI disorders we need to be aware of. Zollinger-Ellison syndrome, which is caused by a gastronoma, which is a neuroendocrine tumor that secretes gastrin. Gastrin then causes a hyposecretion of gastric acid, which leads to increased peptic ulcers. The test is the serum gastrin level, and you would see markedly increased gastrin levels, can be 1,000 times the normal level, and then you can also have peptic ulcers, can be caused by Helicobacter pylori or H. pylori infection, and taking too much NSAIDs such as aspirin. Finally, we have celiac disease. It can also be referred to as celiac sprue. It's an autoimmune response to ingestion of gluten containing grains such as wheat. It's diagnosed usually in adulthood, and this disease can cause malabsorption. That concludes our lecture for the outline for Unit 5. If you have any questions or need further clarification, don't hesitate to reach out, and I will see you over in the next lecture.